Hi, I'm Dr. John Kenworthy. Welcome to this short tutorial on your brain on anxiety and stress. It is essential to know how our brain responds to the stimuli which trigger an anxiety response so that you are equipped to deal appropriately with anxiety. Let me highlight the key areas of your brain that are involved, and then I will explain what happens inside the brain. The thalamus is the central hub for sights and sounds. The thalamus breaks down incoming visual cues by size, shape, and colour, and auditory cues by volume and dissonance, and then signals the cortex. The cortex then gives raw sights and sounds meaning, enabling you to be conscious of what you are seeing and hearing. And I'll mention here that the prefrontal cortex is vital to turning off the anxiety response once the threat has passed. The amygdala is the emotional core of the brain, whose primary role is to trigger the fear response. Information passing through the amygdala is associated with an emotional significance. The bed nucleus of the stria terminals is particularly interesting when we discuss anxiety. While the amygdala sets off an immediate burst of fear, the BRST perpetuates the fear response, causing longer-term unease typical of anxiety. The locus coeruleus receives signals from the amygdala and initiates the classic anxiety response: rapid heartbeat, increased blood pressure, sweating, and pupil dilation. The hippocampus is your memory center, storing raw information from the senses, along with emotional baggage attached to the data by the amygdala. Now we know these key parts. What happens when we are anxious, stressed, or fearful? Anxiety, stress, and of course fear are triggered primarily through your senses. Sight and sound are first processed by the thalamus, filtering incoming cues and sent directly to the amygdala or to the cortex. Smell and touch go directly to the amygdala, bypassing the thalamus altogether. This is why smells often evoke very powerful memories or feelings. Any cues from your incoming senses that are associated with a threat in the amygdala, whether that threat is real or not, current or not, are immediately processed to trigger the fear response. This is the expressway. It happens before you consciously feel the fear. The hypothalamus and pituitary gland cause the adrenal glands to pump out high levels of the stress hormone cortisol. Too much cortisol short-circuits the cells of the hippocampus, making it difficult to organize the memory of a trauma or a stressful experience. Memories lose context and become fragmented. The body's sympathetic nervous system shifts into overdrive, causing the heart to beat faster, blood pressure to rise, and lungs to hyperventilate. Perspiration increases and the skin's nerve endings tingle, causing goosebumps. Your senses become hyper-alert, freezing you momentarily as you drink in every detail. Adrenaline floods to the muscles, preparing you to fight or run away. The brain shifts focus from digestion to focus on the potential dangers, sometimes causing evacuation of the digestive tract through urination, defecation, or vomiting. Heck, if you're about to be eaten as someone else's dinner, why bother digesting your own? Only after the fear response has been activated does the conscious mind kick in. Some sensory information takes a more thoughtful route from the thalamus to the cortex. The cortex decides whether the sensory information warrants a fear response. If the fear is a genuine threat in space and time, the cortex signals the amygdala to continue being on alert. Fear is a good, useful response essential to survival. However, anxiety is a fear of something that cannot be located in space and time. Most often, it is that indefinable something triggered initially by something real that you sense, but that in itself is not threatening, but it is associated with a fearful memory. And the bed nucleus of the stria terminals perpetuate that fear response. Anxiety is a real fear response for the individual feeling anxious, and anxiety can be debilitating for the sufferer. Now that you know how anxiety happens in your brain, we can pay attention to how we can deliberately use our prefrontal cortex to turn off an inappropriate anxiety response once a threat has passed.
My name is Sam Wagner. I'm the author of Malignant Self-Love, Narcissism Revisited. Phineas Gage was 25 years old, construction foreman. He lived in Vermont in the 1860s. While working on a railroad bed, he packed powdered explosives into a hole in the ground, using tamping iron. The powder heated and blew in his face. The tamping iron rebounded and pierced the top of his skull, ravaging his frontal lobes. In 1869, his doctor, a chap by the name of Harlow, reported the changes to Phineas Gage's personality following this horrible accident. The doctor wrote, "Phineas Gage became fitful, irreverent, indulging at times in the grossest profanity, which was not previously his custom, manifesting but little deference to his fellows, impatient of restraint or advice when it conflicts with his desires, at times pertinaciously obstinate, yet capricious and vacillating." He said that Phineas Gage was devising many plans for future operation, which are no sooner arranged than they are abandoned for other, more appealing, but equally feasible alternatives. Phineas Gage's mind was radically changed, so that his friends and acquaintances said that he was no longer Phineas Gage, concluded the doctor. In other words, his brain injury turned Phineas Gage into a psychopathic narcissist. Is this possible? Can a head trauma or brain injury induce a full-fledged personality disorder? Well, not really. Similarly startling transformations have been recorded among soldiers with penetrating head injuries suffered in World War I. Orbitomedial wounds made people pseudo-psychopathic. They suddenly became grandiose, euphoric, disinhibited, and puerile. When the dorsolateral convexities were damaged, those affected became lethargic and apathetic, or in the lingo of their time, pseudo-depressed. A doctor by the name of Geschwin noted that in many cases, both syndromes appeared. The wounded soldiers, became both pseudo-psychopathic and pseudo-depressed. But the Diagnostic and Statistical Manual is absolutely clear. People with brain injuries may acquire traits and behaviors which are typical of certain personality disorders, but head trauma never results in a full-fledged, long-term personality disorder. I'm quoting from page 689 of the DSM. The enduring pattern of personality disorder should not be due to the direct physiological effects of a substance, such as a drug or a medication, or to a general medical condition, such as head trauma. In my book, Malignant Self-Love, Narcissism Revisited, I wrote, "It is conceivable that a third unrelated problem causes chemical imbalances in the brain, metabolic diseases such as diabetes, pathological narcissism, and other mental health syndromes. There may be a common cause, a hidden common denominator, or perhaps a group of genes. Certain medical conditions can activate the narcissistic defense mechanism. Chronic ailments are likely to lead to the emergence of narcissistic traits or a narcissistic personality style. Traumas, such as brain injuries, have been known to induce states of mind akin to full-blown personality disorders. Such narcissism, quote-unquote, is reversible actually, and tends to be ameliorated or disappear altogether when the underlying medical problem goes away. Other disorders, like bipolar disorder, formerly known as mania depression, are characterized by mood swings that are not brought about by external events. These mood swings are endogenous, not exogenous. They are the outcome of biochemical processes in the brain. But the narcissist mood swings, by comparison, are strictly the results of external events, not internal ones. The narcissist perceives and interprets certain events, for instance, the obtaining of narcissistic supply or the lack of narcissistic supply, and these cause his mood swings. But phenomena which are often associated with narcissistic personality disorders, such as depression or obsessive-compulsive behaviors, can and are treated with medication. Rumor has it that SSRIs, such as fluoxetine, known as Prozac, might have adverse effects if the primary disorder is narcissistic personality disorder. They sometimes lead to a serotonin syndrome, which includes agitation and exacerbates the rage attacks typical of a narcissist. The use of SSRIs is associated at times with delirium and the emergence of a manic phase, and even with psychotic microepisodes. This is not the case, luckily, with heterocyclics, MAOs, and other mood stabilizers, such as lithium. Blockers and inhibitors are regularly applied without discernible adverse effects as far as narcissistic personality disorder is concerned. Not enough is known about the biochemistry of narcissistic personality disorder. There seems to be some vague link to serotonin, but no one knows for sure. There isn't a reliable, non-intrusive method to measure brain and central nervous system serotonin levels, so it's mostly guesswork at this stage. Head injury induces temporary narcissistic behaviors and traits. Brain biochemistry and genetic makeup may encourage the formation of narcissistic personality disorder. That's all we know at this stage.